because I really thought about going for help. I was afraid that as a nurse, if I told them I had a drug problem, they would have to automatically report me to the Board of Registered Nursing, and that I would lose my license. So that kept me from reaching out. People at work said, "Can we help you?" And through the disease state, all I heard was, "We're going to get you." You know, so it was really hard to be in that delusional place. What happened finally was that one night I was very impaired. I had used a lot of narcotics during the shift, and in the morning had both slurred speech, and I was having difficulty getting the narcotics record to come out right because it wasn't right. I was having to make things up, and the staff noticed that I was very impaired and called supervisor, who took me downstairs, and to my, of course, great shame and dismay, the San Jose police were called, and I was arrested from the hospital. Now, I always look back on that day because I think it's exactly what I needed. I don't want any other nurse to ever have to get arrested, but it broke the denial. You know, there's something about sitting in Elmwood Jail in your nurse's uniform that I could no longer say, this is a problem, I'm going to get taken care of myself. You know, that maybe it's bigger, maybe I really do need some help. And then as a result, the community in O'Connor Hospital came together and said, we have a nurse who's in trouble, let's mobilize our forces. They had me released from jail and taken right to their chemical dependency treatment center. And while I was in treatment, nurses and physicians got together and said, why is this still happening for nurses? There had been a diversion program for physicians for many years, and physicians were quietly intervened upon and guided into treatment and assisted to return to work. And there wasn't that same network for nurses. It was more the criminal justice system, the punitive system. So the group We Care was started in 1981 so that I could have a place to go when I left recovery and be able to talk about both the nursing issues and the chemical dependency issues as I healed.
And that speaks to that family feeling you were talking about. That's the upside of it, the mobilization, the support. We have prepared a list from Christine Maslach's book, Burnout, to talk about some potential signs that we may be more prone to developing this kind of struggle. Let's take a look at our first graphic. Oh, we have here difficulty with self-esteem and confidence, distortions in limits and responsibilities, overdependence on approval and affection, overachievement, excessive need for autonomy and control. Now, Catherine, you were in your work, and you were saying you work at different hospitals, and you also have a therapy practice, don't you?
Well, since I'm an intern, I don't have a license to practice as a therapist per se, but I do have my own clientele, and I am supervised by a licensed personnel. But I do see a number of people, and often people who know that I'm a nurse outside of my practice ask me how I can kind of switch hats, you know, how I can be in a need-to-fix-it role and control role in the nursing profession and then be able to sit with a client. My only answer is I get to do my fix-its at the hospital and I get to sit quietly with a client. But being in those two roles, it gives me the idea of, gosh, of self-evaluation all the time and introspection. God, I wonder if this could happen to me. I wonder if what my boundary issues are, the limits that you were just talking about. Where am I in all of this?
Okay. Yeah, that was a great list. That was a great description of codependency. I would guess you would agree with that.
Yes, I would.
You know, that when a person doesn't have a self-esteem, you know, and you know, they find that depending on which study you look at, that a majority of health professionals come from alcoholic homes or homes where there's an ill person or a mentally ill person, that we kind of learn this helper-rescuer role, and then we go out and we find a job where we can recreate that. We're really good at that.
You bet.
But when I don't have a self-esteem here, in fact, for most addicted nurses, the last place that we guard, our rest of our life might be falling apart, but we guard the workplace because that's the only place I felt like I was still competent. It's the only place like I still felt like I contributed to the world. And then the cycle, you see, because I needed the drugs to be there in that very stressful situation. I didn't know how to say, no, I won't work a double shift. You know, no, I won't work 5 days in a row. I'm not going to be on another committee. I couldn't set those healthy limits for myself. So I added everything into my life and then used medication to keep it going. Right. And most health professionals start by treating a functional problem, a sleep disorder, a pain disorder, an anxiety disorder. It's very rarely fun and games. You don't have health professionals sitting around in a room shooting up Demerol for fun. It's just not about that. It's about starting on a functional issue and not realizing that we're a real risk for chemical dependency given our backgrounds.
And you know, I know from my own experience as a mental health professional that even in graduate school, I mean, there was a lot of double messages, which is, gee, you know, we really want you to talk about your potential countertransference issues, your own issues that may come up in therapy. But if you did that, you were then somehow labeled, I mean, even as a student, and you learned very quickly to perhaps not state your personal issues out loud, at least in front of other health professionals, maybe talk about in your own private therapy with your friends. And so even from early training, I don't think we're encouraged to go ahead and say, you know, perhaps I have the same concern as the person I might be working with. Somehow we're supposed to be above that or beyond that, and our own humanity, I think, can get lost in the process.
Right.
That we're supposed
I'm the
to have the
helper,
answer.
you're the one with the problem.
That's
and
right.
as long as I stay in that position, when I've got a problem over here, it makes it very difficult for me to turn my eyes around and say, wait a minute, I'm a person with a problem right now.
That's right.
I think also a lot of people go into nursing, at least I did, because I felt so inadequate at home, you know. I couldn't make a difference. And so being a nurse, I could make a difference and I could see the difference. But one of the parts about going into nursing is I wanted to be taken care of. So I let it all out. I want to take care of you. I want to fix your problem. I want to do this. I want to do that. I can do that with drugs. I can do that with dressings, medicine, lots of things. But what I really wanted was somebody to look after me. And I think that's part of the codependency. Yeah.
Yes, being able to identify that, in fact, we're not above being tired. We're not above having personal needs, and in fact that they're crucial. And I think there is that indirect meeting of those needs that shows up in every kind of probably caring sort of profession. I know I talk about that at great length with my students in terms of trying to spot ahead of time what might be happening here. Let's take a look at the next part of our list. We do have another half. Let's see, meeting personal needs through our helping role. Unmanageable anger, failure to confront fears, impatience, impulsivity, intolerance, and maybe overly empathetic, which I thought when I was reading her list was quite interesting. This idea that because maybe I have some pain that I have not even acknowledged, when I get anywhere near your pain, I'm not only going to feel yours, I'm also going to feel mine, and it seems to get so large.
Right, and then the denial that's taking place. You know, to work in a hospital setting, we need a fair level of denial. I can't hold down a 3-year-old for a painful spinal tap if I'm not able to do some rationalization appropriate, you know. I have to hold him, we need to do this test, we need to find out why he's ill. Yes, it's going to hurt, but I'll hold him carefully so it'll go quickly. So there's appropriate denial that we use, but then the denial starts to generalize, it starts to expand. One of the hardest groups to get together for a support group are nurses. You come in, I worked on an oncology unit, and we said, what if we had somebody come in once a month, we'll have meetings, you get some support for the feelings that are coming up. You know the response we got? I don't have any feelings coming up. I don't take my patients home with me. I leave this right here at work. You know, tremendous amount of denial that I could work with dying patients, usually over a period of weeks or months, and get to know them, and that their death would not impact me. So there's a tremendous amount of denial to stay away from that pain that you're saying is very generated by the people that I work with.
Yeah. I was thinking of some of the times in which the denial is so great. One time, I work in a situation in which people come out of anesthesia confused, and so I was kicked across the room against the person kicked my face, and I ended up slammed against the wall, and and I needed my jaw adjusted. It was like right then and there, I thought, oh, no, this isn't going to happen, and I went back to caring for him, and it's the whole denial of I'm hurting, the emotional upset, and everything else. It's like, yes, you have to have denial in order to be professional.
That you might have a human reaction.
That's right. Maybe somebody kicking you is a problem. Yes. Well, and I know that happens even in therapy, because we'll have clients who come in and they may be, I've had interns where their clients are actually verbally abusive to them.
Yes.
But because they're the intern, they're the client, or they're the therapist, supposedly it's not supposed to bother them when their clients are being abusive or being abrasive and that sort of thing. You just sort of move out of that space, and I think it gets harder and harder over time to move in and out. And I imagine what happens, you just get kind of stuck in that place.
Or you do take it home.
Oh, absolutely.
I think on some level that we are like the post-traumatic stress disorder victim, you know, in that, you know, Tim Cermak, when he described it, said these are people who are subjected to a series of traumatic events that lie outside the scope of human experience. And that it's worse if it's of human origin and you're in a system where you don't get support for dealing with it emotionally. Well, that describes any ER I've ever been in.
Right.
You know,
Absolutely.
where you're there and there's human events going on and they are out of the scope of the normal human experience. And the reaction to that, both in the Vietnam vet and in people I think who work in hospitals, is to just get frozen feelings. Deny that it's affecting. Start to distance yourself. I think one of the ways we distance ourselves is that's the patient, I'm the professional.
Right.
Yeah.
You see, that, you know, I watch my husband, he looks at stuff on television just from that, you know, that ER show,
Yeah.
and he goes, oh, I can't look at this. You know, I've got enough book knowledge and everything, I just separate myself from
Right.
that. But you know, that is a human experience. It's not pleasant to see somebody hurting or bleeding or dying, but where do you take those emotions? When you're not in a system where you have permission to do that. I mean, you might have permission to be empathetic with a patient, but you know what? The other nurses that are working with you, you've got maybe 5 minutes to do that because, you know, they're taking care of your 6 other patients while you're doing this.
Okay.
You
So there's
see?
really not a system built in to do that human kind of connection. So how do we take care of ourselves? I mean, we're in these very difficult situations with, you're right, demands that really I think people who don't work in that setting really have a hard time understanding and in fact don't really want to hear about. I know that my friends who are not therapists really don't want to discuss any kind of things that I've been hearing because it's too painful for them to listen to.
That's right.
So what do people do? We have about a minute.
Well, certainly the people in my group have a place where they can come and they can dump some of the feelings and the emotions that may have taken place the day before at their hospital. They have another group of nurses that they can talk about and the level of stress and perhaps the childhood issues that get triggered for them. So a support group, I think, is one way to do that.
I think that just about every nurse that I've ever met needs therapy. And I say that in a loving way. Because of their childhood issues and because of what they go through. And just about every physician that I know needs therapy as well. And therapy in a way of creating boundaries, to be able to be separate from your patients, be able to not take home all of the...
So maybe as we close, we go ahead and encourage health professionals to seek out some additional support to learn to take better care of themselves. And that starts with giving ourselves permission, I think, to do that.
Right.
I want to thank you for joining us.
welcome.
Thank you.
Next week, we'll examine dream work. I'm Mary Crocker Cook. Good night.